afternoon. I'm going to take speaker's prerogative and subtract some time from my presentation in order to orient most of you in this room. First of all, I go back in this a long time. When I first met our father, Irving Selikoff, he was not the chair of occupational medicine and the director of the environmental sciences laboratory at Mount Sinai. These things didn't exist. He was a practicing, brilliant pulmonologist who was beginning to observe these diseases, often at tuberculosis sanatoria, where talk about misdiagnosis. This is where the patients wound up. Others in the room, Dr. Frank, who is our host and chair. Dr. Frank was not only a resident in occupational medicine, he was my medical resident, PGY1. Took great care of my patients. I see everybody else in the room squirming. Steve Levin goes back to when he was occupational medical resident and then colleague for many years at Mount Sinai. We had some intense discussions in 1980 preceding a meeting in Cairo. Curtis Cummings was a resident in occupational medicine. And Mike Harbert and I spent many absolutely thrilling hours in the deliberations of the American Thoracic Society Committee to revise the 1986 statement, which we did in 2004. So that orients you somewhat. What you see is early lung cancer screening experienced from a large occupational population exposed to asbestos and other lung carcinogens, funded by the Department of Energy, and this is one of my proper addresses, the Early Lung Cancer Detection Programs, Center for the Biology of Natural Systems, Queens College, City University of New York. It does not say Mount Sinai. And all of you know Steve Markowitz, who is the director of that center. Some of you know the third name here, Jeffrey Miller, who is our unique thoracic radiologist. He has now read at least 10,000 CT scans for asbestos disease. So, Mike, you would be interested in that. 10,000 CT scans read for asbestos disease as well as for early lung cancer. I'm not going to go into all the things you know about lung cancer already. Lung cancer is really the #1 cause of death of asbestos-exposed people, not mesothelioma, and certainly not pleural disease or asbestosis, which in today's exposure profiles are very unlikely to cause death. So it's really a contest between mesothelioma and lung cancer. And of the two, unfortunately, unless osteopontin comes in there quickly, at this moment, there is no early detection of mesothelioma. So we should indeed put our resources in early detection of lung cancer. This slide has a lot of important information. When we diagnose lung cancer now, it is almost always advanced, localized, potentially curable disease, 15%. Survival, no different than the past 30 years, somewhere also in the range of 13%. 5-year survival, however, with the earliest stage, which is resectable and curable, 70 to 80 to 90%. And if we have time, we'll get into the 90% stuff. Is screening available? Is screening recommended by the appropriate organizations? Yes, for breast, colon, and prostate. No, for the #1 cause of cancer mortality in the general population, let alone in the occupationally exposed population. The lung cancer screening program, about which I'll be speaking briefly, is funded by the Department of Energy in the gaseous diffusion plants which made the uranium-235, which constitutes nuclear weapons and nuclear power fuel. And you could see there are facilities in many parts of the country. This is the K-25 GDP in Oak Ridge, Tennessee, the largest building in square foot in history. It is now being dismantled. So there was a screening program for various occupational diseases among these workers because this is what they were exposed to. And you see it listed: uranium, asbestos, beryllium, nickel, elements beyond uranium, which are also carcinogenic, and of course, cigarette smoke, whether secondhand or primary, and very importantly, subject to the synergism between smoking and whatever else they were exposed to. So this program was already in effect. Dr. Markowitz was running it in 1999. I was an informal advisor when an article appeared in Lancet, and then the next day on the front page of the New York Times, about early detection of lung cancer with CT scan, and that was a single slice machine. Out of 1,000 at-risk people because of their smoking, 27 lung cancers were detected. Almost all of these were stage 1, and only 7 were visible on the X-ray. This next slide and those that follow talk about the screening program we finished last year on 6,000 gaseous diffusion plant workers. We've now completed studies with a 16-slice machine on 2,000 other workers, and those studies will go on for another several years. You see in 3 states, this is the mobile van housing the CT scanner, which traveled back and forth to Portsmouth, Ohio, Paducah, Kentucky, and Oak Ridge, Tennessee. This is our very lovely technician and a patient going through the CT scanner. This is some political hype. Stage of lung cancers detected through this program. We detected 45, of which early stage 1 and 2 were 71%. So just about a reversal of the expected stages. I wasn't going to show any of these slides because they take up too much time, but I must point out to your lower left that white spot is indeed an early lung cancer. And we followed it 9 millimeters, less than a centimeter, about 1/3 of an inch. And this is rather indeterminate, not only as to what it constitutes, but what you do about it, because it's really too small for most diagnostic modalities. So we did what Dr. Harbert mentioned. We followed it, and 3 months later, it was a 1/2 centimeter larger, and indeed it was a stage 1 lung cancer. So we concluded from this study that CT screening, all CT screening is helical or spiral, can detect early stage lung cancers in a real world setting. We're talking about small communities in 3 different states. We're not talking about Philadelphia and its 5 or 4 medical schools, or 3 or what. We're not talking about major metropolitan areas. We were dependent on the local physicians' facilities and hospitals, and it was either dismaying or invigorating for me to note that the resources and the approach and the facilities available in Oak Ridge, Tennessee, or Paducah often exceeded those available in the borough of Manhattan. The last point, that a radiologist can designate nodules that are suspicious with a high degree of sensitivity and specificity. This bugaboo of false positivity is not as enormous as non-advocates of screening would have us to believe. Nodules which are not suspicious are either benign, that's easy, because there are very clear indicia of being benign, the vast majority of indeterminate. And you simply can't say, and those can be managed with limited interval CT scanning, and very few of them turn out to be cancerous. This is our new scanner, the 16-slice machine. This isn't quite as mobile a van because we're only doing this so far in Oak Ridge. This is our new, somewhat less attractive technician. This is the International Early Lung Cancer Action Program, headed by Dr. Claudia Henschke at Cornell, who put this on the map in 1999. A paper was published by the consortium last October, just a few months ago, looking at 31,000 screenings in these 38 institutions around the world. The only center which was not either a cancer regional center or a major academic medical center was ours. So I have to put in that pitch because it tells you that the resources and the ability to do this are there in the developed world. So we screened almost 32,000 people. We detected 403 at baseline screening, 75 in annual screening. And of these 484, 412 were stage 1. So that's even a little better than before. And their 10-year survival has been analyzed at 88%. This shows this graphically. You see the data from the international consortium. The red line shows survival out to 10 years. The red line showing resected stage 1, 92%. So if you had your cancer detected and it was stage 1 and you had it resected, which is what the advice is, and almost invariably what is done, then you have above a 90% chance of making it 10 years. We always have to talk about risks and benefits. So the problem is radiation exposure. We use a low-dose technique, which is what made screening possible, because you cannot use standard radiation dosage. The loss in image quality is almost undetectable. There's some anxiety. You're being inserted into this machine. You're worrying about the results. With proper communication, this is not a great problem. There is a cost to this, and there is the risk of unnecessary invasive workup and surgery, which are rather rare, and when done, are often indicated for another dire condition than lung cancer. The benefits are you could detect the disease at an earlier stage, you could treat many more patients at a treatable stage, you increase survival, and the goal is to reduce lung cancer mortality. And you know that this is the argument now raging that do we or do we not decrease mortality, and do we wait the NIH-sponsored controlled clinical trial to demonstrate that? It is very strongly the opinion of all of us in this program that we have the information, that we have the follow-up to permit us to overcome the 3 epidemiological vulnerabilities of screening, lead time and length time bias, which simply say you're picking up the same disease at an earlier stage. So if the patient is there for another year or 2, that's all you're giving him is a year that he knows he has the disease as opposed to a year he doesn't. The big bugaboo is overdiagnosis. This claims that the majority of lung cancers are detected at a small size and they are indolent. They will not grow and become malignant. And to address this question, when we look at these cancers, when we resect them, they look the same. They are as aggressive malignancies as any other cancers. The one kind of cancer which is indolent is the bronchoalveolar carcinoma. This may be more slow growing. We know what it looks like. It looks different, and it's rare. It's no more than 15% of screen-detected cancers, not the majority. Small size counts. If you have stage 1A, under 3 centimeters, it's better than having stage 1B, greater. If you have stage 1A under 3 centimeters and the tumor is under 2 centimeters, your survival chances are better. So detecting it early not only means you're resectable and curable, it's more likely that you will be cured. And the last piece of evidence is a paper that is soon to come out in the journal Chest, which I had nothing to do about writing, looking at the cancer registry of one of our largest states over a long interval, looking at almost 20,000 stage 1 cancers, of whom 1,400 were not operated upon. So these are generally much poorer risk individuals, and yet their fate was very similar. So here was, in a way, the other arm of the trial. These are patients who were, for some fortunate reason, because screening wasn't being done, detected with very small lung cancers. They did not have treatment. Their survival, their mortality, their life expectancy were exactly what we expected. So that concludes my presentation, and we'll look forward to, what, a break now or another presentation? Dr. Levin, which is the reason I came to hear Dr. Levin.